All right, everyone. So we'll go ahead and get started on chapter 35. This is going to be broken into three sections. The first video we'll talk about like normal growth and development and anatomy, physiology considerations of newborn or of children, pediatric patients. Remember, pediatrics referring to the words of like children in medicine. And so that'll be the first part of the video. And then we'll talk about uh, like how do we assess children. It does change, and so an important concept is children are not just mini adults, they're their own little thing each age. And so this is why we have an entire branch of medicine, pediatricians, right, dedicated, and entire hospitals dedicated to children, because they're not just mini adults. And so be aware that things change. And then we'll go into the medical portion. So we'll talk about all the medical consideration of children: asthma, croup, bronchitis, epiglottitis, stuff like that. And then that'll be the second video, which is going to be a good review of, because we'll talk about some things that do happen in adults, just a nuance in how they change with children. And then the third video will be trauma type stuff, and then we'll do the review questions. So let's get going. So again, children are not just mini adults. They're different in every way, right? Anatomically, physically, emotionally, they're different. And so you need to respect that these are not just little adults. And so illness and injuries that children sustain and their response to them vary based on age and developmental level. It's important to remember that children are not small adults. Fear of EMS providers and pain can make the child difficult to assess. And so I used to work in a pediatric hospital for a couple years in the ER. And so it's important that children are actually pretty smart. And so you just need to be honest with them. So, like you don't start IVs, but if you were starting an IV, you tell them like you're going to feel a pinch or a sting over here in your arm, and you just tell them that fact. And so don't lie to them, because if you lie to them once, they're not going to trust anyone in the healthcare team for the rest of that day or visit or however long. And so just be honest with them, and explain what you're doing to them. They deserve that, and it works really well if you just explain it to them. And kids are squirmy. Like, it's really hard to do things to kids by force, like to hold them down to get a blood pressure or something like that. It's really difficult and annoying. So it's better just to have them calm. Okay. And so once you learn how to approach children of different ages and what to expect while caring for them, you will find that treating children also offers some very special rewards. It does. Taking care of children is very, very fun and rewarding. And with that, I will say that you're not just treating the child, you're almost always treating the parent as well, emotionally treating them, right? And so the parents need reassurance and guidance and explanation and comfort, right? And so you're treating both the parents and the child, okay? When you're when you're treating a child, right? You're taking care of the whole family. And so when caring for a pediatric patient, you must care for the parents and caregivers as well. A calm parent usually results in a calm child. And so when I'd have like a fussy kid or something, I would let the mom hold the child. Or, if I need to take a kid's blood pressure, I'd have mom hold and hug the child in her lap. And usually that'll keep the child more calm. And so this is a useful tool, is to have the parents hold or touch, or, sometimes too, if I need to listen to the child's lungs, I'll listen to mom's lungs first. And then I'll ask if I can do it to the kid, right? Or just say, hey, it's your turn, right? And so I look, it doesn't hurt, something like that. And so sometimes you can demonstrate procedures like a blood pressure or, an exam on the mom or the parent, and then do it on the child. And that works pretty well, because they'll see, oh, it's not painful, Like to take a blood pressure, I'll say, oh, my little machine's here is going to give your arm a hug, right? So explaining, or take your blood pressure, that's scary to a 3-year-old, but oh, my little machine here is just going to give your arm a little hug. That's it. So you would use age-appropriate words like that. And so this is where it's important to remain calm. I have seen this personally, where EMS providers get all spun up because it's a kid. And it's like, well, I get we don't run them every single shift, but just, chaos is contagious. So be calm, be composed. It's fine. So we're going to talk about these different stages. I've seen these stages test on an exams, to where they'll say, oh, the child is 8 months old. They're an infant. Oh, the child's 2 years old. They're a toddler. The child's 5. They're preschool age. School age can be 6 to 12. Adolescence is 12 to 18. Really 13, 18 is what I consider. But anyways, those are things to consider. Okay, they'll just straight up throw out an age and say, is this an adolescent? Is this a school age child? Whatever. And so infancy is defined as the first year of life, but the first month, this is an important distinction. It's called the neonatal or the newborn period. So the first month, coming to a test near you, The first month is known as the neonatal or newborn period. You must know that. So 0 to 2 months, the baby's going to spend the majority of their day just sleeping and then eating. They sleep a lot, but they're having an exponential growth in that first year of life, and so it takes a lot of effort to grow, and so they sleep a lot, and so um, they respond mainly to physical stimuli like being picked up or being moved. Okay, they cannot tell the difference between parents and strangers generally. Don't I mean Generally, yeah, that and it's also because their senses are not fully developed yet. But crying is one of the main modes of expression in this first part of life. They probably won't have like what we call a social smile where they're smiling and giggling and stuff. Um, so keep that in mind. So 0 to 2 months is an inconsolable infant. Could be a sign of significant illness. So a baby that cries, 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 and you just cannot. No matter if you change their diaper and you feed them and you burp them and you lay them down and you try to console them and you rock them, you cannot get them to stop crying. We call that inconsolable. Then that may mean there's something wrong. Okay. So again, a baby can't raise their hand and be like, "Yo, bro, my stomach hurts." They just cry, and so that's the problem. This is the challenge, I should say. And so, also, babies are predisposed to hypothermia. Remember, just like newborns, fresh out of the womb, they can't they don't shiver and stuff like that to stay warm. And again, they're not going to raise their hand and be like, "Jacket, please." And so, just keep that in mind. This little guy is my nephew, Mr. Harvey, and that was him when he was a month old. And this is him. He was a little older. I'm gonna guess like 3 or 4 months, 3 months. And so the 2 to 6 month, they're more active at this stage. They may follow objects with their eyes. So it would be normal for a baby at 2 to 6 months to kind of look around or try to be following. It would be abnormal if it's like they're looking through you and they're not really tracking objects. So we call that tracking. They should be able to track things with their eyes. And so again, persistent crying and all that could or okay, persistent crying or irritability, lack of eye contact can be an indicator of serious illness, depressed mental status, or really, delayed in development. And so, a lot of times we'll pick up autism and stuff like that by a baby like not having what's called a social smile or not tracking things with its eyes appropriately and stuff like that, or even deafness and blindness in babies. Okay, this is Mr. Hobby when he was a little bit older, and so the infant becomes mobile, which predisposes them to physical danger. So at the 6 to 12 month mark, they can start crawling first, and then around a year ish, they might start walking, give or take 2 months. So like 10 to 14 ish months, they can start walking. And so they could place things in their mouth. Remember, babies will put everything in their mouth. Okay, so everything is a choking hazard to a baby. They may cry if separated from their parents. That is called social anxiety, where they get separated from the mom or the parent, I'm sorry, uh, detachment, to where when they get attachment syndrome. I don't remember. Basically, when you take a baby from the parent, they'll cry, and then so persistent crying or irritability again is a sign of serious illness. And so, um, the assessment you'll observe the infant. So when we do assessments, a lot of this can be done just by you want to do all of your visual inspection first prior to touching the baby because you may make them cry. It's not as common for a baby to cry just from looking at them, although I've done it, right? Like sometimes they just see you and they just start crying. But observe infants from a distance. Caregivers should hold the baby during the physical assessment. That is a very good tool that I mentioned earlier. It consoles the baby. It makes them comfortable. Provide sensory comfort, so warm hands and the end of the stethoscope. So, before you put your stethoscope in your ear, you can rub it on your hand like this to warm it with friction and then place it on the baby's chest. Because if you place like an ice cold stethoscope on a baby's chest, they're going to cry. Okay? Anything that's painful, do it at the end. So, like, do your full exam and then, a blood pressure is not painful, but it can be irritating, but get a blood pressure at the end. Get a blood glucose, for example, if you have to do a glucose at the very end. The baby's going to cry. And let me tell you this too. A crying baby is a healthy baby. A crying baby is a very good sound, right? Because that means they have an open airway, they're moving air. So a crying baby is a healthy baby. That is like when you're on an ambulance and you hear a baby crying, it's music to your ears, right? That means they're healthy. Okay? Only healthy babies can cry. When you see a baby who is not crying, that should be crying, or that is crying and can no longer cry, they're crashing, right? They're in shock. They could die. So be aware of that. A crying baby is a healthy baby. So after infancy until up to eight, toddler is after, so between 1 to 3 years. Okay, terrible twos, them terrible toddlers, and so just be aware. And so the problem with toddlers is they get into everything. Because now they can walk, and as they get into like the ages 2, 3, 4, they start resisting you and having attitudes and like being defiant and stuff like that. And so just be aware. And so at the 12 to 18 month, like I said, they can walk, and so this is the babies that will walk or crawl into a pool or something like that. And so just be aware that they don't have fear because they don't know, oh, I can't swim, and the shiny pool, I will sink to the bottom and drown. And so this is why pools should have fences if you have toddlers. And so this assessment of a toddler, it's more common for them to have stranger anxiety, okay? And they will very likely resist being separated from their caregiver. So again, keep them with the caregiver. And this caregiver could be the babysitter, it could be a sibling, like an older sibling. You want to keep them with someone familiar if mom and dad aren't available, the teacher, the aunt, something like that, grandma. You want to keep them with who they know while you're doing your exam. But the cool thing about toddlers is like they're like moths to a flame with iPads, and so sometimes you could put on like Miss Rachel or something like that and try to distract them with like your phone. I don't know, Paw Patrol or something like that. You could put it on your phone and just let them watch it while you gotta do what you gotta do. I used to do that. I used to give kids my phone on the ambulance just to keep them entertained. Anyways, persistent crying can be a symptom of serious illness or injury for like the eighth time. Um, Previous medical experiences may lead to hesitation towards you. And so this is the thing when you walk up in like a healthcare uniform, like kids will associate, if they've had a bad experience at the doctor's office or at a hospital or in an ambulance before, kids are fairly smart and they remember that. And so they may associate you with that. And so they might resist your care. So age 3 to 6, children have a rich imagination. They can be fearful of pain, right? They may believe injury is a result of earlier bad behavior. Okay. Foreign body aspiration and airway obstruction continues to be at high risk. Okay. Um, and so it's probably not as high of a risk, but it is as like a 3 year old. But like, sure, a 5, 6 year old could certainly choke on things. And so to assess the preschool age child, communicate simply and directly. You don't want to use major words like, I'm going to assess your blood pressure. Now we'll do an abdominal examination, right? Can I look at your tummy, right? Can I touch your tummy? Stuff like that. You have to use words that they're going to know. And so, uh, the majority of the history will be obtained from the caregivers or the family. Uh, Appealing to the child's imagination may facilitate examination. Again, so sometimes you can just distract them by telling a story or giving them the phone or something like that, and just distracting them long enough. Playing music, letting them read a book, someone reading a book to them. So again, don't lie to these patients. I'm telling you, they're like little lie detector tests. They know when you're lying, and so and if you lie to them and they catch you in a lie, they're not gonna let the rest of the team do their job. They're gonna have a high level of distrust, and so that's the problem with that. So with children, typically we do a head to toe assessment, but with children, you could start with the feet and move to the head. It's just because if you start at the head, it can be very overwhelming for them sensory wise, but sometimes they'll let you look at their feet and then work your way up. Okay, that's a technique you could use. Now, keep in mind, in like a 2, 3 year old, they don't care if they're naked, but to do the exam or just in their diaper, I should say. But if 4, 5, 6 year old might. So just keep that in mind that you want to respect their modesty and keep them covered. Now, 6 to 12 year olds are going to start acting like little mini adults, and so they're going to think more concrete. They can respond sensibly and honestly to questions. Can help take care of themselves. School is important, right? So I'll usually an icebreaker. I'll use like, oh, are you in school? What grade are you in? Who's your teacher? Do you like your teacher? Do you like your classmates? What have you been learning? Stuff like that. Just talk to them. Okay. Now, the interesting thing about age 6 to 12 is they start to somewhat, especially around 6, begin to understand that death is a thing, but they don't fully understand death usually at that age. Now, at 12, they would, but they start to realize what death is. They understand it. So, around age 4, 5, and even up to 6, really around 5, children may not understand what death is, and they could think that death is temporary or death is their fault, or not everyone dies, or death is a punishment, like, oh, you took grandma away as a punishment because she died. So they don't fully understand death yet around 5. So to help gain trust, talk to the child, not just the caregiver, right? So I'll be like, hey man, you just be cool with them, right? How you feeling? You in school? What grade? What school do you go to? Stuff like that. Just kind of talk to them. School's important to them. And so, do you like reading? Oh, what's your favorite subject? You like math? Oh, cool. Stuff like just talk to them. And so, if possible, give the child choices. So, one of the favorite things that we would do at Cooks is we would give children choices. And so we would say, okay, you know, we have to go to this other room to go take a picture, like do a CAT scan or an X-ray. Do you want to walk there? Do you want to ride in the bed, or do you want to ride in my wheelchair? What do you want to do, right? I didn't give them an option of not doing it, but I gave them an option of we're going, right? How do you want to get there? And so if they decide, oh, I've always wanted to ride in a wheelchair, so let's go in the wheelchair, come on. And so like it empowered them to make a choice. And you could do the same thing with a kid like taking a blood pressure, right? Of like, all right, we got to take a blood pressure, or my machine's got to hug one of your arms. Which one do you want? Do you want this arm or that arm? Oh, this arm, okay. And you're empowering them, right? I didn't say, can I? I said my machine needs to give one of your arms a hug. Which arm do you want the hug on, right? And so that's a technique to use. Don't ask, can I take a blood pressure? It's not going to end well. They're going to say no. And then if they say no, then you have to like way undo all that damage. So the better way to do is like, I'm going to give one of your arms a hug with my machine. Which arm would you prefer? And so you're giving them options, and so they'll buy into your care a lot better at that point. Okay. Um, yeah, and ask only questions let you control the answer. We don't bargain. Okay, much like the United States, we don't negotiate with terrorists. No, I'm just kidding. But really, don't bargain or debate with them. Like I said, you can give them choices. Just what all the answer choices are ones that you like. And so, answer the child. Allow the child to listen to his or her own heartbeat through the stethoscope. You could do that. More common, I'll just listen to mom, or I'll listen to myself and be like, "Look, there's no pain involved. I'm just listening." Okay. The school-age children can understand the difference between physical and emotional pain. Provide simple explanation of what is causing their pain and what will be done. Okay, so like splinting and stuff like that. Like they have a fracture, like okay, we're gonna put this board around your arm and it's gonna help straighten it out to where it's not gonna hurt as bad. We call this a splint. We're gonna be real gentle and careful with you, and I think when this is done, your pain's gonna be a lot better. Stuff like that. You're just explaining it to them. Now, puberty begins around 13-ish years of age. 11, 12, 13. And so obviously there's going to be some very strong concerns about body image and appearance and privacy. Modesty is incredibly important to pubescent teenagers, men and women. And so just keep that in mind. There's usually not a great reason to do a genitalia exam at that age unless there's like, unless it's indicated, but usually not indicated. And so the problem with this age group, and we've all been here, I look back and think of some of the crazy things I did, is you feel indestructible. You feel immortal. You know, I could jump my bike like they did on MTV because, I mean, nothing bad would happen to me, And so just be aware of that you could, so they engage in what's called risk-taking behavior, like all the crazy stuff me and my brothers used to do. Just because you feel indestructible, you're invincible. And so they also will struggle with independence, loss of control, body image, sexuality, peer pressure, all those things start, y'all aren't that old. Some of you are 18. You're still experiencing this. And so, yeah, adolescence so this is what we'd like the teenage years, okay? 13, 18, can often understand complex concepts and treatment options, allow them to be involved in their own care. Now, remember, an 18-year-old can make their own decisions, okay? And so keep that in mind. Even if they're in high school, if they're 18, they're in the eyes of the law, they're an adult. And so they can refuse care and all that stuff, okay? Doesn't matter where they live. If they're living with mom, and mom wants them to go to the hospital, but 18-year-old boy does not. I mean, it gets hairy because the 18-year-old boy is an adult in the eyes of the law. Generally, EMT of the same gender should do a physical exam if possible. That's just a good rule around this age. I would say anywhere from like 13 to 22-ish. I personally I don't like to be alone with like a female of that age, uh, just because it just creates issues, right? He said, she said type stuff, and so if you can have a chaperone, or if that's not possible, have the like if you have a female partner, have them assess female, stuff like that. It's a comfort level too. It's really for your safety as well, um, like to protect you from accusations and stuff like that. So, whoops. All right. So the anatomy and physiology. So keep in mind, I mean, it's really quite remarkable how fast babies are growing, and children are growing from the time they're born to the time, 6 years of age. Like that's a lot of growth, and so there's these changes that are occurring, and so we have to do our planning accordingly. And so one thing that's tested commonly is the pediatric airway is smaller, okay, and so it's also more flexible. And so the problem is you can see like this is an adult's airway. See, remember the trachea is the airway tube in the front of the throat. Well, the problem with the kid is these cartilaginous rings aren't fully developed yet and stiff. So it's like a bit like a bendy straw that can actually bend. Compared to an adult's, it's more like a metal straw. Like it's going to be a lot harder to bend and break that. But a kid's, you can kink it a lot easier. Okay, and so be aware you can kink a kid's trachea by hyperextending their neck or flexing it forward or choking them. You know, their airway is more likely to become kinked. Okay, and not only that, it's more flexible, and it's shorter. It's like it's a shorter diameter. Okay. And so the lungs are smaller. So what does that mean? They don't need a whole on the BVM. You don't have to collapse the bag with every breath on a 5-year-old, right? It's just enough to get chest rise. Their lungs are much, much, much smaller. Now with that, they tend to breathe at a higher respiratory rate. And the height of the heart is higher in the child's chest. It's sitting higher up. Okay, so that's something to know, I guess. But the glottic opening, so this is like the where the vocal cords are, is higher and positioned more anteriorly, meaning it's more towards like their nose, um, like this way. And the neck appears to be non-existent. So the kids don't have as large of necks compared to adults. They have really big heads. So in an infant, a third of their height is their head. Okay. So as the child develops, the neck becomes proportionally longer as the vocal cords and epiglottis achieve anatomically correct position. Okay. So they're going to have a larger, rounder occiput, and that's the back of the head. And the reason I'm telling you that is that it's so big, they can like end up hyperextending their neck and kinking that airway. Proportionally, they'll have these really big floppy tongues, and the epiglottis. Remember, that's this little, like if this is the trachea, this is this little flap that normally when you breathe, it covers, or I'm sorry, when you swallow, it covers this. It'll flap down and cover it like this. And so that's usually a lot bigger. Okay. The cartilage rings are not as developed, so they're not going to be as stiff in the airway. This is what makes it kind of floppy. And then they have a narrowing funnel shape of the upper airway. So this funnel shape takes place at the level of the cricothyroid cartilage right here. Okay. And so if something's going to get stuck, like a button or a battery or something like that, in the child's airway, it's probably going to get stuck right here, which is like a terrible place to get stuck. It's right in the middle of the trachea. So the diameter of the trachea is about the same as a drinking straw. Okay, you can imagine how small that is. The airway is easily obstructed with secretions, vomit, blood, swelling. And remember, infants are what we call obligatory nose breathers. Okay, they have to breathe through their nose. And so this is why it's so important to keep an infant's nose clear. Again, they can't raise their hand and be like, hey, bro, can you blow my nose? This is why you have to suction infants' noses out. We'll show you how to do this in class. Pretty aggressively, especially if they get like a viral infection like RSV. They have tons and tons of mucus production, and they can become in severe respiratory distress if their nose gets clogged up. They are what we call obligatory nose breathers, meaning they're obliged. They must breathe through their nose. And so the respiratory rate can be quite higher in newborns, right? 20 to 60 times a minute. So a general rule is I'll look at a baby, and if I see them breathing about once a second, well, then they're breathing 60 times a minute, and that's normal in a newborn. So children have an oxygen demand twice that of an adult, and so they're at an increased risk of hypoxia. What kills children? Hypoxia kills children. This is further demonstrating that, right? So if children die, what did they die from? They died from hypoxia, okay? So how do we resuscitate children? We focus on reversing hypoxia with ventilations. The muscles of the diaphragm are not going to be as strong. Um, and so that's one of the things to think about. But pressure on a child's abdomen can cause respiratory compromise. So remember, the diaphragm's pushing down on the gut contents every breath. But if you're putting a lot of pressure on a child's belly, that can interfere with the diaphragm's ability to push those guts out of the way to kind of like take a breath in. So use caution when applying straps of a spinal mobilization device. Um, if you strap them down real tight, right, then they may not be able to breathe. And this would be the equivalent of you. Like if I strap you down really, really tight, you're not gonna be able to breathe. But especially in a child, because their diaphragm's weaker, and their abdominal muscles are weaker. And so anatomy of the airway. Gastric distension can interfere with movement of the diaphragm and lead to hypoventilation. So if you bag a child too aggressively and pump air into their stomach, the stomach can become distended and take kind of rob the place where the lungs would be using to inhale and exhale. And so when you rob that volume, the kid will have hypoventilation perhaps. Breath sounds are more easily heard in children because of their thinner chest wall. Now, with that, there's what we call bleed and so, bleed over. And so, if this is a kid's torso, right, and here's their head, we would normally listen like here, or here, 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 right? And so, what I'm saying is, when you put your stethoscope here, you could very well be hearing sounds from different areas, okay? Because their chest wall is so thin, and so that's something to think about. It's called bleed over. And so an infant's heart rate can be 160 beats a minute or more. In fact, that'd be fairly common. And so keep that in mind. Like it's not, remember we start resuscitation when it's less than 100. We start full blown chest compressions when it's less than 60 on infants infants. And so children are able to compensate for decreased perfusion by constricting the vessels in the skin. Okay, I mean, I'm reading this to you, but I don't have a lot to add. Signs of vasoconstriction include pallor. Remember, pallor is like the whitening-ish of skin tissue because they will constrict the vessels in the skin. So they're robbing the pink color from the skin, the blood, and they're shunting it to the core. Weak distal pulses in the extremity. Delayed capillary refill. Remember, capillary refill is the greatest indicator of perfusion that we have, especially in children. So we should always be checking peripheral capillary refill in the fingers and the hands, the arms, right? And then also check it in the core as well. So these are normal heart rates, probably worth knowing. Okay, definitely worth knowing of what's normal. Um, and so, you'll see when they get to around 10 years of age, it's almost adult-like, but it's not fully adult. Okay. And so, pediatric nervous system is immature, undeveloped. So this actually develops all the way pretty much up to puberty. And so, and it's not well protected. And so remember, their head is like a third of their height, and so it's kind of prominent and susceptible to injury. The occipital region of the head is larger. The subarachnoid space is smaller, leaving less cushion of the brain. Remember, if this is the skull, this is the dura mater, and here's the brain, right? There is this what we call the subarachnoid, or I'm sorry, this would be the skull. This is the dura mater. This is the subarachnoid space right here, and so this is or the subdural subarachnoid space. And so what I'm saying is the baby's head is, or their brain is not as big as their skull when they're first born. And so what you have to worry about is that it's not as cushioned. This is one of the reasons shaken baby syndrome is so fatal and so terrible is if you shake a baby is because their brain can really rattle around in their skull because it's not very big. It's not as big as their skull, I should say. And this is why brain tissue and the brain vessels are fragile and prone to bleeding and shearing. Okay. So the pediatric brain requires higher cerebral blood flow, oxygen, glucose. Remember, this brain is growing exponentially. This is one of the only times the brain grows is in childhood. And so the brain's at risk for secondary brain damage from hypotension and hypoxic events. Okay. Spinal cord injuries are less common, but if injured, is more likely to be an injury to the ligaments from a fall. So remember, when you're young, you're more likely to break ligaments and tendons and like have dislocations, sprains, and strains as opposed to a broken bone. Now, don't get me wrong, kids can break bones, and they do, but you're more likely, this is just demonstrating this example to where if an old lady falls, she's going to break her vertebra. A little kid falls, they may break a ligament or tear a ligament. Okay. So for children, it's the same thing. Manual inline stabilization, follow the protocols, whatever those are for your agency. So abdominal muscles are less developed, and so you have less protection from trauma. That's what I was talking about, like when you put the weight on a kid's belly, like strap them down. Their abs aren't very strong yet. They're abdominal wall muscles, and their obliques and all that. And so it's just not as protected from trauma. And so the liver, spleen, and kidneys also are proportionally larger and situated more interiorly and close to one another. So again, you're more likely to get damaged because they're just more prominent, right? They're taking up more space. They're more exposed, okay? Less protected. Now the musculoskeletal system, remember that the epiphyseal end of what's called epiphyseal growth plate. So there's growth plates in bones and long bones. And so if a kid breaks a bone through this plate, they could end up with stunted growth in that extremity. And so that's one thing to keep in mind. That's what they're talking about in the second bullet. But the first bullet's saying that, as a result of growth plates, the children's bones are softer and more flexible. Children's bones are more flexible. So can anyone remember what type of fracture you tend to see when a kid breaks a bone? All right, I'm giving you a hint with this color. It's called a green stick fracture. Remember, if you were to go out to the tree right now and take a stick and break it and it splinters instead of just fully snapping, that's called a green stick fracture. And that happens in kids' bones because their bones are more soft. Just like a green stick is more soft compared to like a dead tree branch. And so bones of an infant's head are flexible and soft. Remember, there's these soft spots in the skull, like the anterior fontanelles and the posterior fontanelles, where the full head is not fully fused in infants. It takes a few months for this to happen. And so there's a divot in the skull, or soft spot, I should say, and that's called the fontanelle. So if that's severely divoted, you might think dehydration. If it's bulging, you might think shaken baby syndrome. Okay? And so we use that clinically to assess children. You obviously shouldn't push very hard on that, but because right below that's the brain. The thoracic cage is highly elastic and pliable. It's again, baby's bones are soft, their joints are soft. Okay, and so, but with that, since they're so soft, the vital organs like the heart and lungs are a little bit less protected because again, it's soft. Like those tissues are soft. The integumentary system. Remember, integumentary system is referring to like the skin. And so thinner skin and less subcutaneous fat in a child, that's the difference from an adult. The composition of the skin is thinner and tends to burn more deeply and easily with less exposure. So what is that? If you were to hold a cigarette lighter underneath my hand for 2 seconds, I might get a first degree burn. If you were to hold a cigarette lighter up underneath a kid's hand for 2 seconds, you might get a second or third degree burn. Okay, their skin's just not as resistant as mine is. Mine's thicker, older, stronger. Okay. Their higher ratio of body surface area to body mass leads to larger fluid loss and heat losses. This is one of the reasons we have the pediatric rule of nines, okay? Because they have a different body surface area in general, one. And then two, the resuscitation for a child when you start talking about like IV fluids and stuff is different compared to an adult. We resuscitate them more aggressively with fluid. Scene size up, I don't have a lot to add to any of that. Other than I will say, I've seen it, you see this quite often with sick children. The parents will meet you at the curb, like they're waiting on you, and you get there and they hand you their unresponsive or dead child, and their seizing child or something like that. So just never lose sight of how valuable and sacred this profession is, to where a stranger will meet a stranger at the sidewalk of their house on their very worst day in their very scariest moment and hand you their most prized possession, their child, right? The most important thing in their life, their child. They're going to hand it to you and say, fix it, right? And in a month from now, you will be allowed to do that. And so it's very, very powerful, the sacredity of working in EMS, that we have that privilege. So that's a pretty common thing where they'll meet you at the curb. Because they can just pick up kids and just carry them. Also, it's very annoying. Sometimes they'll start driving to you, and we call that a rendezvous. You really don't want to do that, but when I used to work out in the county, that used to happen almost all the time. All the time. They would just start driving to Stephenville, and we would just head out the highway, and try to meet them. It's a mess. Chaos. All right, so note the position in which the patient is found. Look for possible safety threats. Patient may be the patient may be a safety threat if he or she has an infectious disease. Do keep in mind meningitis. Children are like, especially daycare children, school age children. They're little vectors. They have all sorts of these interesting viruses and bacterial infections, sometimes several at once, and so they can get you very sick. So wearing a mask and PPE actually, or at least washing your nasty hands, becomes very important around kids. I mean, when I did my pediatric rotation last year, I was sick for 6 weeks straight. It was terrible. I had like and I was being so careful, like wearing a mask and washing my hands. It doesn't matter. And so just be aware that they have like all these very highly contagious diseases, and they just share them. Now, this is tested quite often. This is called the Pediatric Assessment Triangle. And so what they're saying is these three things help us form a general impression of a child. Remember, your general impression is our across the room assessment. And so it doesn't require you to touch the patient. You're just looking across the room assessment. And it can be formed in less than 30 seconds. And so I've seen this tested in a lot of different ways. So know everything about that. And then also, what we're just looking at, okay, what's their appearance? What do they look like? Oh, the kid is, sitting on the bed, smiling, playing with his iPad. Appears no in distress. They're breathing fine, right? Their skin color looks nice and pink, right? That's a happy kid, right? Or you walk into the room and the kid is sitting in a pile of vomit. He is unconscious and breathing, 100 times a minute or 60 times a minute. And you'd be like, okay, well, it looks like they maybe just had a seizure or something like that, and they're cyanotic. And so we use this clinically. And so, in fact, when I used to work at the hospital at the Cook Children's, we have what's called the podium medic. And so you would sit at this podium at the doors of the ER, and every patient that walked through the door, very quickly, what's going on today? Oh, even and I would take like a look, and I would do my quick pediatric assessment triangle. Okay, the kid looks terribly ill, red, right? Or we'd sometimes just take them back to our resuscitation room, or yellow or green, and that would determine how quickly are we going to triage this patient, or are they going to go to a waiting room, things like that. The PAT does not require equipment, so again, it's the appearance, work of breathing, and circulation. Do know that. So for appearance, you're going to note the level of consciousness, their interactiveness, their muscle tone. Are they looking at you? Are they moving around? Are they unconscious? You could use the ABPU again. Can we get the baby to wake up? If we tap on their toe, on their heel, their sole, are they going to start crying? These are all things we're going to do to try. Well, that would be touching them, but you know what I'm saying. You would be trying to stimulate a response of this baby if they're unresponsive. Normal level of consciousness. Are they acting age appropriate? Are they acting afraid to see me, which might be normal for a 6, 7, or 3, 4, 5, 6, 7-year-old child, right? Are they being shy because they're 8 years old and they're shy and they're hiding behind mom? Are they making good eye contact? Do they have a social smile? These are things that you're looking for. And so they have this what's called the TICLS mnemonic. And so the idea of being the podium medic at Cook Children's was I have to decide, is this child sick or not sick? And this is a gift that comes with time, right? With assessing a lot of patients and knowing a lot about medicine. So I would have to say very quickly, this patient is sick or not sick. So they're going to wait or they're not. And so we look at their tone, interactiveness. Are they consolable? The look or gaze. Are they when I open up their little car seat thing? Are they looking at me like, who's this guy staring at me, right? Or are they just looking straight through me? Are they looking in one direction and not coming back towards me? Are their eyes bouncing? Are they having a seizure? These are all things that we would use. And then their speech and cry. Okay. Work of breathing again. This is there's some things that we would use like abnormal airway noise like stridor, accessory muscle use. So in kids, you'll see retractions up here in the clavicular space, subclavicular space, and so you might see like some muscles contracting here with breathing. You'll certainly see abdominal breathing, what we call belly breathing, head bobbing. So when a kid's breathing and their head's kind of bobbing like this, right? That is ominous. Nasal flaring is when the nostrils will flare with breathing. And so this is when they're breathing really hard. You'll see with each breath they get bigger, smaller, bigger, smaller. That's not normal, okay? And if I were to tell you to go run, you might have a little bit of nasal flaring, but that's not normal in kids. That means respiratory distress. Tachypnea, the tripod position, drooling, all of these things are things that we look at and assess very quickly in the pediatric assessment triangle. Circulation. So remember, And when a child goes into shock, they're going to shunt blood away from their periphery to their core. And so you'll see skin pallor, and this can even be called, you'll see something called mottling. And I meant to put a picture in here of what mottling looks like. But mottling is, I'll have that picture in the next video. You need to know what mottling is. But mottling is this pattern on the skin that tells you, like, oh, that's poor perfusion. You've seen mottling before on children, even when they're cold, you can see mottled skin. But just be aware, mottling is an idea that, okay, they're either cold or they're in shock and they're shunning blood away from the skin. From the physical, the PAT, the pediatric assessment triangle, you'll decide if the patient is stable or requires urgent care. So again, we're deciding sick or not sick. If they're unstable, you're going to do the XABCs, treat life threats, and transport immediately, right? If they're stable, you're going to continue with the remainder of the assessment process. So remember, if you're doing your PAT and you notice the kid's not breathing, the exam stops. You address the life threats, okay? Remember the XABCDE, right? Exsanguination, this means bleeding out or bleeding to death, airway, breathing, circulation, disability, and exposure. So if the airway is open and will remain open, you'll assess respiratory adequacy. If the patient is unresponsive or has difficulty keeping the airway open, you'll ensure that it's open. This may be a head tilt chin lift, a jaw thrust, or you might also have to clear it with mucus. Sometimes you could use a bulb suction. Remember those little blue things? I have one over there, but I forgot to grab it. Or you could use a suction can or a suction yonker. Okay. Remember, we suction the baby's mouth. I think it's like 5 or 10 seconds. It's not 15 seconds because their vagus nerve is more active. Always position the airway in a neutral sniffing position. And so sometimes what we have to do is we have to pad underneath the kid's head. And so let's we go like this. All right, this is kind of like drawing a kid, I guess. And so what would happen is, what am I doing? I drew this wrong. Their shoulders are, this is not drawn to scale. This is not going well. Their shoulders can be generally small. This is such a bad picture. To where what you might have to do, this will make more sense in class, is you might have to pad underneath their shoulders to keep their head in a steady line like this. Because if this pad wasn't there, what would happen is the neck might look like this. And so then it's not sitting in like in an equal position. So remember that this is the occiput back here. And so to put the neck in a solid line, you might have to pad underneath your shoulders. Use a look, listen, feel technique for breathing. Sometimes with kids, you can put your hand on their chest and do that for the whole chest rise and fall, because as they breathe fast and they're not breathing a great tidal volume, as is normal in children, then you might have to um, um, put your hand to assess that. Belly breathing is considered normal in infant or adequate, but this becomes a problem in like 1, 2, 3 year olds. They shouldn't be belly breathing. Okay, so this is when they're using their abdomen a lot to aid in breathing. Bradypnea is an ominous sign they're about to go in cardiac arrest. If you see that, they probably will go into cardiac arrest if you do not intervene very quickly. Very ominous. Patient assessment, right? Circulation. See if the patient has a pulse. Where do we check the pulse in infants? The brachial pulse. That's over here in the arm. If they're bleeding or in shock, in infants, you would palpate the brachial or the femoral pulse. The brachial pulse is the most common site. The children older than 1, you can palpate the carotid pulse in the neck. But remember, if they're less than 1, we go for the brachial or the femoral pulse. A strong central pulse will usually indicate that the child is not hypotensive. What does that mean? So if you can palpate a good brachial pulse, but the kid's kicking and screaming and you can't get a blood pressure for the 3rd time, you could just document that they have a strong, central pulse. And so that would be indicative of not being hypotensive. So sometimes we just have to use that. Like, oh, the patient has strong bounding pulses. Okay, well, they're normotensive or they're not hypotensive. And so we'll use that clinically. And so the weak or absent peripheral pulses will indicate decreased perfusion, maybe hypotension, shock, something like that. And so now tachycardia could be an early sign of hypoxia, and this is in adults and children. But remember, children are inherently tachycardic. Remember that table earlier with the inherent heart rates of children? So, don't be like, oh my God, the kid's tachycardic and their heart rate's 130 on a 1.5 year old or a 2 year old. That's not tachycardia. So that's why knowing that table becomes important of like, oh wow, yes, a 2 year old should not have a heart rate of 200. Okay, that is tachycardic for sure. And so that would be maybe indicative of like fever or like hypoxia or something of the kind. So we use cap refill, skin temperature, skin moisture. Talked about that. You can use the APHU scale or the pediatric GCS scale. I don't even know what the pediatric GCS scale is. Their pupil response, that could be helpful in determining neurological function. Okay, that should be pretty brisk. Uh, Symmetrical movement of extremities. So you see the kid's only moving one arm, right? Even a newborn's only moving one arm. You might think, oh, they may have broke this arm in delivery or something like that. And so, the body should be symmetric, obviously. So, that's something to assess. The only thing I'll add on exposure is the whole heat loss. Hypothermia in children is actually a very important thing to avoid, and it's avoidable. Just keep the child warm, keep them covered, increase the temperature of the ambulance if needed. But this whole exposure hypothermia thing can actually wreck out a kid pretty quick and cause shock and all sorts of problems clinically for you. Transport, so I mean, generally, okay, any hospital should be able to care for a child, okay? But any emergency department should. Now, with that said, does that mean that every child should go to the closest hospital? No. It's the closest what? Most appropriate hospital. So sometimes it is more appropriate to go to Cook Children's or a specialized pediatric center is generally going to be your best bet, you know, depending on the region and stuff. But, you could take a patient to a local hospital sometimes. Like cardiac arrest, if a kid's in cardiac arrest, it is the closest hospital. But if a kid is like, has a like say they have a seizure disorder, yeah, I'm gonna bypass the closest hospital to go to Cook Children's or to like a pediatric hospital, I should say. Okay. So we could also consider the clinical problem. Are they followed by a specialist? Do they need immediate ALS care now? Your local protocol. So what is your medical director telling you to do with children? Does every child go to the pediatric center, or do they all go to the closest hospital? How comfortable are you with this type of care? Again, we don't run kids every single day, so a lot of people are uncomfortable with children. So if you're comfortable with it, go for it. Go to the further hospital. But if you're uncomfortable, go to the closest hospital. So if the patient's condition is urgent, initiate immediate transport to the closest appropriate facility. Notice that didn't say the closest facility, the closest most appropriate facility. Now, if they're less than 40 pounds, you should transport them in a car seat. And so what you would do is you'd ask the parents to get their car seat and just you strap it to the stretcher. We'll show you how to do this in class. And follow the manufacturer's instruction to secure the car seat to the captain's chair. There is a way to also secure this to the stretcher. There's also a way to secure this to we have like a car seat that rolls up. It's a soft car seat. It's called a PD mate. And so we'll show you what those look like in class as well. This is interesting. Patients who require spinal immobilization, you could immobilize these sometimes on a long backboard or another suitable spinal mobilization device. Sometimes a KED works well for this, or what's called a short backboard. Sometimes those work okay on children in certain scenarios. So patients in cardiac arrest, so you would use a device like the PD mate. They would secure them to the stretcher. Um, the goal is to secure and protect the pediatric patient for transport ambulance. I'll show you what a PD mate is in class. It's just easier to show you because there's a technique to like installing them on the ambulance structure appropriately. Uh, so taking the history of a patient depends on the age, right? You're not going to talk to an infant, but a preschool age or an adolescent, yeah, you could probably talk to the patient. Questioning the parents or child's about the immediate illness or injury should be based on the child's chief complaint. If you suspect abuse, which we'll talk about, sometimes it's nice to talk to the child alone just for a moment, or like sexual things, like patient has vaginal bleeding or lower abdominal discomfort. You would need to find out, is this patient potentially pregnant? Okay, so when was the first day of your last menstrual cycle? Are you sexually active? Things like that. And so sometimes that's easier to ask when the parents aren't there. And so, because they'll be more honest, the patient will be more honest. And so that's something to keep in mind. Uh, I don't know. So one thing I'll add is fever is pretty common in children, and so be aware that fever in adult and children you can get tachycardia because your body's going to have an increased metabolic rate at that point, and so you'll have a higher heart rate. That's normal with fever. You could also be asking, and so we ask this with children as well. How are they eating? How are they drinking? What's their urine output? So with a baby would say, how many ounces are they taking? How many, when's the last time you fed them? How many wet diapers have they had? Right? And so they're like, oh, I've only changed their diaper once today. And it's like a newborn. That's a problem. So yeah, just that's something you would want to know is how many ounces are they taking? Are they eating? Are they drinking? How many wet diapers have they had? Stuff like that. Those give us the inputs and outputs of children. And so, you'd want to ask about rashes. Eczema is fairly common in children. And so so just because a child has a rash doesn't mean that's related to their issue today. So, a better way to phrase that is this rash new? When did you first notice this rash? Has this rash grown in size? Things like that. Okay. Obtain the phone number of caregivers if they're not able to come with you to the hospital. That is astronomically rare, but if that does happen, then yes. Now, I have had it happen in older children, or really even young children actually, where it's like a single mom, and so they'll be like, "I have three other kids. I need to put them in the car, get them in their car seats, and I'll meet you up at the hospital. I am coming." Right, but she has other kids. She can't just leave them at the house. She's alone, and so that does happen. Actually, I'll say that actually happens fairly often. So sample history, we've covered this. OPQRST, same as children. Now, something with children we can use is called the Wong-Baker Pain Scale, and so this you've probably seen this before, where it'll be like, you know, the crying phase, and then like a sad phase, and then it's like 1 through 10. And so basically, we'll use this to help. So you could ask the kid, point to which one of these describes your pain, right? And so they'll point at the Wong-Baker Pain Scale. Okay. So the physical exam, secondary assessment of the entire body should be used when patient is unresponsive or has a significant MOI. It's the same as with adults. The focus assessment should be performed on patients without life threats. Okay. So the focus assessment is where like, oh, you have abdominal pain. Well, I don't need to do an extremity exam on a 4-year-old with abdominal pain. I need to focus on their abdomen. Okay. That's a focused exam. We focus on the problem. Uh, and they're saying this twice where I feel it might show up on a test, but infant, toddlers, and preschool children should be assessed starting from the feet and ending at the head. And so school age children, so what's school age children? Ages 6 to 12, and adolescents 12 to 18 should be approached head to toe. So in our assessment of children, we look at their head for bruising. What's the medical word for bruising? Hematomas, the color of bruising, ecchymosis, right? Swelling, hematomas, okay? What's the medical word for swelling? Edema. We assess the fontanelles in infants. So this should be soft. It should not be bulging, and it should not be severely depressed. If it's severely depressed, you think dehydration. If it's bulging, you think shaken baby syndrome or perhaps meningitis. Okay. The nose, you should look at, is the nose clear? Do they have a bunch of snotty boogers? They need to be suctioned, right? And so this is where we use bulb suctioning or even a catheter sometimes to suction them. Drainage from the ears may indicate a skull fracture. What do we call that test when you put gauze next to the kid's ear or anyone's ear, and there's a little area like this? What do we call that? Halo sign, right? And so that's called the halo sign. Battle sign may indicate skull fracture. What's battle sign? That's periorbital ecchymosis, so bruising around the eyes and bruising behind the ears. Means that you have broken the base of the skull. It's a basilar skull fracture. Drainage of pus from the ears could mean an ear infection. Very, very common in children. So again, a 6-month-old can't tell you my ear hurts. What will they do? They will pull at their ear because it hurts. They'll be fussy, inconsolable, stuff like that. Examine tracheal area for swelling and bruising, right? Note that if the patient cannot move his or her neck or have a high fever, so if the patient's not wanting to move their neck, you might be, with fever especially, you would be thinking, oh, this is meningitis, you better put a mask on, because meningitis is contagious. And so just be aware of that we call that nuchal rigidity, when they don't want to move their neck because it hurts. So the chest, you'll examine for penetrating trauma, lacerations, bruises, or rashes. You'll feel the clavicles and every rib for tenderness and deformity. So children break the clavicle, the collarbone right here, pretty common. It's from falling on an outstretched hand, so you'll see this in like soccer matches and football matches. And so it's a pretty commonly broken bone. And so remember, with a clavicle fracture, they're going to hold their arm tight and close to their body. At the back, you'll look for lacerations, penetrating injuries, bruises, rashes. So maybe a kid got tackled in football in the back, and now they have flank bruising, and they're urinating blood. So you might think, oh, there's a kidney injury or something to that effect. So kidney injury is fairly common in contact sports, especially like football and stuff like that. In kids, you would look for distension and what's called guarding. And so guarding is when they're tensing their abdominal muscles to try to protect them, to protect the abdomen from pain from you palpating it. So let's refresh. If a patient has right lower quadrant abdominal pain, you don't want to start touching immediately on the right lower quadrant. That's where you end. That's where you end your exam at. And so I'll start in the left upper, left lower, right upper, and I finish in the right lower. What's in the right lower quadrant abdomen of a male or a female? The appendix. So someone with right lower quadrant abdominal pain, especially in a kid, you'd be thinking appendicitis. Okay? You could note for tendernesses or masses, um, this can happen. Yeah. Like intussusception, you might feel a sausage-shaped mask, and pyloric stenosis, you might feel an olive-shaped mask. So there's different things you could look for clinically by palpating the abdomen. But remember, you go to the problem area last. Extremities don't have a lot to add on this, right? You look for warmth, color, joint size of joints. Remember, one thing I'll add is we compare one joint to the other. So let's say like they're like old lady or not. They're like, my right wrist hurts. I look at the right wrist and then I compare it to the left wrist. They should be equal in size. If this one's 3 times the size, that's worrisome. If they're the same size, then I'm like, okay, they're either both swollen or this one's not that swollen. And so we use that clinically. So remember, with extremities, you compare one side to the other. You assess for symmetry, always, old or young. Okay. Now I will say, blood pressure is usually not assessed in patients younger than 3 years, because usually it doesn't matter. If they have a pulse and they're trying to have a blood pressure, you might try, but you're gonna make them mad usually. But we did take their blood pressure in the pediatric hospital I worked at. And so again, if you do take their blood pressure, which is more common than not, you would want the parent or caregiver to hold them and console them. Sometimes they wrap them up kind of tight and give them a hug and almost restrain them, but they disguise it as a hug, and that will help your vital sign assessment. Okay. Now, there's appropriate size pediatric cuffs. We'll show you what these look like in class as well. There's like infant, neonate, or infant, neonate, infant, pediatric, and there's like toddler, small child, small adult, adult, large adult. So there's like 5 different sizes, I think. And so we have all of those in class to show you. I know they're there. So I want to show you what those look like. And so we have both the manual cuffs and the blood pressure machine cuffs. All right, so if you've ever wondered, which this is a formula we need to know, how to figure out the blood pressure of a child, this is how you do it. So it's the child's age in years times 2 plus 70. So let's say it's an 8-year-old child. This is what their systolic blood pressure should be, the top number. Okay, so let's say it's an 8-year-old child. So you do 8 times 2 equals 16 plus 70 equals 86. That should be the top number over something, I don't know. And so just keep that in mind. Also, we count respirations longer in children because they're breathing faster. So it's for 30 seconds, and then you double that to get your count, okay? So it's not uncommon for like a 1-year-old to be breathing 60 times a minute. Okay, like that really does happen, or 45 times a minute, or 40 times a minute. So watch for that. I already told you my trick. If they're breathing once a second, they answer 60. Okay, so I use that. In infants and those younger than 3 years, evaluate respirations by assessing rise and fall of the abdomen. That's a good point. They'll be belly breathing. Remember, that's fairly normal. And so you could just look at the abdomen moving, or you could like place your hand on their chest if they allow it, and count that way. So you would assess the pulse rate for 1 minute. Where do we check the pulse in someone less than a year of age? Either the femoral or brachial area. Okay. pupils with a pen light. Pulse oximetry is really great. I will show you in class as well. A lot of times in children, their thumbs are really small, their fingers. So what we'll do, like less than a year, we'll always we put the pulse oximetry on their toes. That's like their big toe. It's the best place to do it. Trust me. And you can also put it on their earlobe, right? And so also you can take a blood pressure on the leg. Again, we will show you how to do that in class as well. Reassess the pediatric patient's condition as necessary. Obtain the vital signs every 15 minutes if stable. Obtain the vital signs every 5 minutes if unstable. Continually monitor respiratory efforts, skin color and condition, and level of consciousness or interactiveness. All right, that's the end of this video. The next one's going to be much more intense. We start talking about the different pathologies like bronchiolitis and croup and epiglottitis and meningitis and all these infectious disease issues and asthma and anaphylaxis. So that's the next video. So it's going to be very important. So I'll see you in just a bit.